Hello, dear friends. Today we are talking about arterial hypertension and hypotension syndromes. About 30 to 45% of all adults suffering from arterial hypertension. This is 1.13 billion people. Expected prevalence by 2025 is 1.5 billion people. This condition is a major risk factor for ischemic heart disease, for heart failure, for cerebrovascular disorders, and peripheral artery diseases. Let's discuss about normal physiology, and let's remember that we're recognizing systolic and diastolic pressures, differences between them we call as a pulse pressure, and blood pressure depends on three major factors: the work of heart, especially from heart rate and cardiac output rate, and next is vascular resistance or peripheral resistance, and volume of circulating blood or blood volume. Increasing only one parameter may cause the arterial hypertension. Here is the influence of autonomic nervous system to the heart and peripheral vessels. You remember that stimulation of beta-1 adrenal receptors cause increasing strength and heart rate. Stimulation of M cholinergic receptors cause weakening of strength and reduction of the frequency of heart contraction. Also, you should remember the ventricles of heart do not have parasympathetic innervation. Bradycardia is accompanied by an increasing systolic pressure and decreasing diastolic pressure, and tachycardia accompanied by a decreasing systolic and increased diastolic pressure. With a pathological increase in the tone of the arterioles, for example in edema, sympathetic and hormonal influences, or under the influence of additional factors, for example in case of increasing blood volume, an emergency mechanism for lowering blood pressure is activated. This mechanism activated in kidney, and filtration pressure in kidney increase, which causes an increase in filtration and an increase in urine output. As a result, blood volume decreases and blood pressure in the artery decreases. With frequent episodes of increasing pressure, delicate renal vessels become hardened and lose their ability to respond quickly to hypertension, and arterial hypertension becomes permanent. Arterial hypertension is a syndrome, the main symptom of which the repeating increasing of blood pressure above 140 to 90. Prolonged increase in blood pressure leads to accelerated damage to the arteries, the rapid progression of atherosclerosis and sclerosis of small arteries. As a result, with insufficient blood supply, all organs and systems of the body can be affected. First of all, the organs that are most sensitive to hypoxia and high blood pressure are affected. This is target organs: heart, kidney, of course, this is eye, retinopathy may develop, and of course brain, which caused by appearance of encephalopathy and even stroke formation. Here is classification of hypertension stages according to blood pressure level, presence of cardiovascular risk factors, hypertension-mediated organs damage, or comorbidities. This was represented by European Society of Hypertension, and you see here three risks of developing: low risk, moderate risk, and high risk. The main diagnostic method for diagnosis of arterial hypertension, of course, recommend measuring of blood pressure. For measuring, you should ask patient avoid smoking, drinking alcohol and coffee, and an hour before the measurement. Also, measurement should be carried out after 15 minutes of rest. It's important to measure blood pressure at rest. And it of course should be appropriate BP cuff, and also you can measure by or in brachial artery on arms or leg arterial pressure, and measurement should be carried out 3 times, at least interval should be 3 minutes. Average of last 2 measurement is taken as a true. In the presence of arterial hypertension, measure blood pressure on both arms and legs. On the legs, blood pressure is normally always higher than on the hands, but in case of, for example, peripheral arterial diseases, Now, maybe decrease pressure in leg. For these, you should measure ankle brachial index and brachial index. This is a relation between the ankle systolic pressure and brachial systolic pressure. Normally, this is within 0.9 and 1.29 range, but in case of decreasing and when this pressure less than 0.9, we should suspect the peripheral arterial diseases. Here is examples in prone and supine position how you measure pressure in legs, and you should put stethoscope on the popliteal artery. In case of measuring of ankle pressure, you should put stethoscope on the arterium tibialis posterior. Arterial hypertension, there are two types, primary and secondary. Primary, we have increasing blood pressure as a main syndrome of disease, whereas secondary, this is arterial hypertension, is the one of symptom of diseases. Which symptoms may, which disorders may result in arterial hypertension? Of course, there's kidney diseases, damaging of renal vessels, endocrine diseases, acquired heart defects, congenital malformations. And primary essential hypertension, this is diagnosis of exclusion. To put the primary hypertension, you should exclude all these disorders by in the examination and investigation of these all disorders. Which disorders which can result in arterial hypertension very large. For example, this kind of endocrine disorders and other causes, all these diseases can result in arterial hypertension. Arterial hypertension may develop because of adrenal dependent causes like pheochromocytoma or hypercortisolism, Cushing syndrome, Cushing diseases, hyperthyroidism, acromegaly, Cushing disease, acromegaly and gigantism. For example, thyroid dependent causes like hyper and hypothyroidism, even in vitamin D deficiency syndrome. Renal diseases, renovascular diseases, or neurogenic collagen vascular diseases. Neurogenic causes like brain tumor, autonomic dysfunction, sleep apnea, drug and toxins, alcohol using. So many disorders may result in arterial hypertension. Here is levels of arterial hypertension. Normal pressure, systolic pressure from 100 to 139, diastolic pressure from 60 to 89 pressure. You see optimal, this is less than 120 to 80, whereas normal 120 to 129, and diastolic is 80 to 84. High normal, this is 130, more than 130 till 139, and high normal for diastolic pressure 85, 89. And there are three grades of hypertension, and also we are distinguished as isolated systolic hypertension when we have increasing only systolic pressure. Here is categories of BP. There are we are recognizing office BP when office BP is more to 5 millimeters Hg from home BP, and primary hypertension. Primary hypertension mostly connected with many risk factors like obesity, hyperlipidemias, sedentary lifestyle, maybe hereditary predisposition, all and also psycho-emotional stresses, and pathogenesis of hypertension, primary hypertension, closely connected with persistent psychological stresses which activate the hypothalamus, pituitary, adrenal and sympathetic adrenomedullary axis, and as a result we have requirement pro-inflammatory cells which cause the low-grade vascular inflammation, which cause the activation of oxidative stress and pro-inflammatory cytokines, and as a result we have endothelial dysfunction and hypertension. Clinically, hypertension manifested by triad of symptoms. this includes headache, noise in ears, and blurred vision. A combination of these symptoms is so characteristic that even in the absence of a tonometer or BP cuff, it reliably indicates an increase in blood pressure. Clinical manifestation of arterial hypertension syndrome only with a rapid increase in blood pressure. A gradual increase even to very high values as well as stage long-term hypertension may not be felt by the patient. Other symptoms can be varied, like dizziness, nausea, vomiting, shortness of breath, tachycardia, and paresis. Besides clinical picture, of course, you should provide the laboratory instrumental investigation. For these, we have a routine laboratory tests, which are represented by European Society of Cardiologists. There are hemoglobin level and hematocrit level, fasting glucose level, blood lipids and triglycerides, potassium and sodium level, blood uric acid, creatine, and GFR. Of course, level of GFR is also very important because arterial hypertension may accompany it by damaging of target organs or may develop because of kidney disorders. Blood liver function test, urine analysis, and of course ECG test. ECG we need for detect the left ventricular hypertrophy, which is more common in arterial hypertension. Urine albumin creatine ratio level to detect the elevation in albumin excretion, indicative of possible renal disease. Blood creatinine and GFR level to detect possible renal diseases, and fundoscopy. And more screening methods also we use echocardiography and carotid ultrasound. On ECG, you see left ventricular hypertrophy signs. You remember from ECG lecture, left ventricular hypertrophy signs, ECG signs are represented by left atrial or left axis deviation. You see the biggest R on the first lead, and we have positive on first lead R, and also you see a circular line index more than 35. You see the biggest R on V5, V6, and deep S on V1, and coronary criteria also here is more than 25 in men and 20 millimeters in women. Symptomatic arterial hypertension or secondary arterial hypertension is a hypertension with an established cause. The frequency of secondary hypertension is 5 to 10%. That means primary character more than 90%, whereas secondary only 5 to 10% of all causes of hypertension. Which indirect signs can suggest the symptomatic or secondary arterial hypertension? Data from anamnesis, physical and laboratory tests gives you a history of kidney disease, for example, or changes of laboratory parameters, of, for example, urine. Also, this secondary hypertension, they are resistant for therapy if even for using of 3 groups of antihypertensive drugs. Also, they are characterized by rapidly progressive or malignant hypertension and absence of hypertension in the family history, and characterized by increasing diastolic pressure than systolic pressure. There are 5 types: renal secondary arterial hypertension, endocrine, central, hemodynamic, and drug genesis. Let's start from renal secondary arterial hypertension. This may occur because of 2 types of renal damaging. First, renal parenchyma damaging. Next is renal vascular damaging. Renal parenchyma damaging may be because of glomerulonephritis, pyelonephritis, nephrosclerosis, whereas renal vascular damaging connected with the damaging of vessels of kidney. Renovascular should be suspected if beginning before the age of 30 or rapidly progressing over the age of 50, resistance to treatment according to 3-drug regimen, and deterioration of renal function after administration of angiotensin-converting enzyme inhibitors. These enzymes normally, of course, they decrease the blood pressure, but in case of renal vascular damaging, especially both side renal vascular damaging, ACA inhibitors, they can cause the increasing pressure. Also, for renal vascular character malignant hypertension and relapses of pulmonary edema, sudden deterioration of renal function in a patient with hypertension, and of course vascular murmurs or noise in the epigastrium or lateral and iliac abdomen side, and character generalized atherosclerosis. That's why for the gold standard for the diagnosis of renal artery stenosis is abdominal aortic angiography. Here is examples or causes of renal vascular hypertension. For example, the most common cause is atherosclerosis of renal artery, you see, and the second place is maybe fibromuscular dysplasias or aorta arteritis or Takayasu disease, especially second and third type, with the involving to the non-specific process branches of aorta renal artery. For this reason, renal vascular disorders developed by renin-angiotensin-aldosterone system activation. This activation starts from the reduction of average dynamic pressure below 70 mmHg, which causes the releasing of renin, increasing renin production by juxtaglomerular apparatus. Increasing renin production causes activation of angiotensin again. Angiotensin 1, under action of angiotensin converting enzymes, converts into the angiotensin 2. This is very high power vasoconstrictor. This angiotensin 2 has 3 actions. First, this is cause vasoconstriction. Vasoconstriction cause increasing peripheral resistance of vessels. The first part. Next action of angiotensin 2 for a long time, if influence the vessels, will cause the thickening of wall of vessels and narrowing of lumen, and last action activates the aldosterone. Aldosterone, you know, this is hormone of adrenal cortex, which cause the sodium and water retention and increase the blood volume. This renin-angiotensin-aldosterone system cause increasing blood pressure because of, in one hand, because of vasoconstriction and increasing peripheral vascular resistance. On the other hand, increased blood volume because of sodium and water retention. Renoprivative mechanism. Renoprivative mechanism of hypertension belongs to the damaging of parenchyma. You know, in kidney we have releasing not only renin, also kidney may release suppressors like prostaglandins. Normal prostaglandins, they are cause enlarging dilation of renal arteries. In case of deficiency, we have privileges of vasoconstrictors over the vasodilators, and as a result we have also developing of hypertension. Next reason for increasing pressure, of course, this is endocrine reasons of secondary arterial hypertension. On the first place, pheochromocytoma. In more than 80% of cases, a single benign tumor from chromophilic cells of the adrenal gland, maybe extraadrenal localization along the thoracic and abdominal aorta at the hilum of the kidneys in the bladder. Pheochromocytoma mostly may associated with the other endocrine disorders like gynecomastia or Marfan syndrome. You see, according to the clinical course, there are three forms are distinguished of pheochromocytoma. They are latent form, or crisis form, or constant form. Latent, mostly asymptomatic, and blood pressure rises very rarely, and the death of the patient may be during the first crisis. Crisis increase in blood pressure against the background of normal blood pressure outside the crisis, and constant increase in blood pressure with mild crisis. It may occur, it may character to 25% of patients. If first form is finding at autopsy, third form very similar to primary arterial hypertension. But the most character crisis course or crisis course of disease, this is when blood pressure rises within a few seconds and may reach the maximum systolic pressure till even 250 till 300 mmHg, whereas increase also diastolic pressure, characterized by tachycardia, by fear, severe pallor, sometimes cold sweat are noted, goose skin, vision and hearing are impaired. There is a strong thirst, frequent urination, body temperature may rise, and in the blood you could find leukocytosis and hyperglycemia. Crisis is often complicated by impaired cerebral circulation and pulmonary edema. Crisis usually rarely last up to 30 minutes, and during the investigation you can find increasing epinephrine and norepinephrine level, and also ketoclamine metabolic levels increasing in urine, like vanillin mandelic acid increase in urine, and also in urine appear glucosuria. How you diagnose? Of course, daily excretion of metanephrines increase and plasma ketoclamines increase. CT scan shows you a tumor in adrenal gland, or may tumor developing may tumor may be in extra adrenal gland localization. For this, you use radioisotope scanning and aortography or selective angiography. Next is Cushing disease and Cushing syndrome, or hyperthyroidism, hypercortisolism. Hypercortisolism, in 70% of cases of hypercortisolism is Cushing disease, 15% adrenal adenoma or cancer, and ECTH producing extraadrenal tumors in 15%. We have particular clinical changes like disproportional obesity, moon-like face, buffalo neck, bright purple striations, muscle atrophy in women, virilization, atrophy mammary glands, amenorrhea in men, hair loss and impotency may develop, and also character diabetes because of glucocorticoids, they are contrainsulary hormones, and osteoporosis. In blood, you could find leukocytosis, erythrocytosis, eosinopenia, this distinctive feature. For this, you could recommend the Thorne test. For the introduction of ACTH, the number of eosinophils in the peripheral blood decreases to less than 50 per 1 millimeters. If the number of eosinophils is more than 10 or more than 100, then the disease is excluded. Also, character hyperglycemia, glucosuria, hypocalcemia, and excretion of 17 Ks in the urine increase. And also daily excretion of cortisol exceeds 100 milligrams. You can provide 2 dexamethasonic tests, small and large dexamethasonic test. 2 small dexamethasonic test you provide by giving 1 milligram of dexamethasone at midnight, and you should check the concentration of cortisol in plasma in morning. Purpose for providing this test, checking of feedback mechanisms in Cushing syndrome, this mechanism is disrupted, and the secretion of steroids with the introduction of dexamethasone is not reduced. In a large dexamethasone test, you provide to distinguish the Cushing disease from the syndrome of ectopic ACTH secretion and adrenal tumors. Also, you could use the X-ray of skull and tomography of adrenal gland. Next, for Cushing disease, increasing pressure, blood pressure, connected with, of course, connected with the increasing blood volume, and of course peripheral resistance of vessels. Next is Conn disease. Conn disease mostly develop because of adrenal adenoma and bilateral adrenal hyperplasias. Clinically, Conn disease or hyperaldosteronemia connected with the aldosterone function, and aldosterone, cause sodium and water retention and increase blood volume. Increasing blood volume cause arterial hypertension, either labile or stable course with the appropriate clinic, and hypokalemia develop because opposite electrolyte for sodium, this is for potassium, this is sodium, and if we have retention of water and sodium, we have a losing of potassium. That's why I develop hypokalemia. Plasma potassium content less than 3.6, and character weakness, muscle weakness, transient paresis, tetany, and also myalgia, seizures of muscle weakness, polyuria, polydipsia, metabolic alkalosis, impaired glucose tolerance, and multiple renal cysts. In urine, you could find polyuria and nocturia, increasing of nocturnal diuresis and isostenourias, and also urine reaction is alkaline. In the blood, character hypokalemia, hyporeninemia, and hyperaldosteronemias, and of course low plasma renin activity and increased secretion of aldosterone, and a ratio of plasma aldosterone to renin more than 20. Next reason for hypertension, thyrotoxicosis or hyperthyroidism. All diseases which result in hyperthyroidism, increasing T4T3 production, may result in hypertension because of increasing first heart rate. In case of increasing T4T3, we have activation of metabolic rate, as a result increasing heart rate, increasing peripheral resistance, and heart rate cause pulsating struma of medium density, and also for these disorders, character, for example, for grave disease, character exophthalmos, eye and eye symptoms, and neurological symptoms, and tachycardia, heart rhythm disturbances, any atrial fibrillation, for example. Because of increasing of metabolic rate, our patient will lose weight. Also, activation of metabolic rate cause diarrhea, and in blood ESR increasing, and of course in blood will be increased T4 and T3 level, and decreased TSH level. Next reason is acromegaly. This is overproduction of growth hormone. Acromegaly represented by thickening of soft tissues, enlargement of limbs, changes in bones with disproportional growth, especially feet, hands, lower jaw, joints, pain, macroglycia, joint pain, and often visual impairment, bitemporal hemianopsia character, and cardiovascular disorders like hypertension and even heart failure. How you can screen? You can find out the increasing of insulin-like growth factors, and growth hormone inhibitory glucose test provide. Acromegaly is likely if 2 hours after taking 100 grams of glucose, the level of growth hormone increase. And also hyperphosphatemia character. Its degree corresponds to the activity of acromegaly, and in 30% of cases, glucose tolerance test is impaired, diabetes is found. Next is hyperparathyroidism. This single adenoma may be 70%, or hyperplasia of all four parathyroid glands. All may develop because of cancer. Hyperparathyroidism characterized by increasing blood calcium level, which cause the parathyroid, which cause the skull decalcifications, nephrocalcinosis, or kidney stones, or peptic ulcer and pancreatitis. How you can diagnose? Of course, except arterial hypertension, these represented by increasing serum calcium and parathyroid hormone levels. Normally, hypercalcemia leads to decrease in parathyroid hormone level. In hyperparathyroidism, you see increasing serum calcium and calcium level and parathyroid hormones level. Next is climacteric hypertension, a decrease in blood pressure against the background of hormonal therapy, as well as a tendency to normalize blood pressure after a decrease in subside of climacteric pathological symptoms are evidence of climacteric hypertension. Of course, this may occur in a woman who is more than 45-50 years old. Next is central secondary arterial hypertension, mostly caused by encephalitis, polymyelitis, tumors, and brain traumas. Main features are moderate, mainly systolic hypertension, asymmetry of headache, bradycardia, changes in the fundus of predominantly stagnant nature, organic neurological symptoms, may characterized by epilepsy, form, seizures, personality changes, or sign of intracranial hypertension, and character lack of hereditary predisposition. Hemodynamic secondary arterial hypertension. First type is sclerotic hypertension or senile hypertension, associated with a decrease in elasticity of aorta, sclerosis changes, or atherosclerosis. It's noted in the elderly, mainly in women, when systolic blood pressure is significantly increased and diastolic within normal limit. Other types of hemodynamic secondary arterial hypertension are coarctation of aorta. In coarctation of aorta, also will increase pressure because of narrowing of aorta, most often at the point of transition of the arch to the descending section, and you see in upper extremities we have high pressure, and lower extremities we have very small pressure. And diagnostically, of course, for diagnosis we should you can use BP measuring, BP measuring in legs and arms, and also X-ray and ECG. For hemodynamic secondary arterial hypertension, also two secondary arterial hypertension, hemodynamic secondary arterial hypertension belongs aortic insufficiency and also patent ductus arteriosus. Aortic insufficiency, you remember from valvular heart disorders, increase systolic pressure and decrease diastolic pressure. We have very high pulse pressure, and patent ductus arteriosus also characterized by increasing blood pressure. Next, a very rare syndrome, but it takes place, Geisbeck syndrome. This syndrome characterized by erythemia and hypertension, mostly occur in male, character for smokers. They have increasing viscosity of blood and plus blood hypertension. Next type is drug induced or medicine induced secondary hypertension. Some medicines like corticosteroids, non-steroid anti-inflammatory drugs, alcohol, monoamine oxidase inhibitors, oral contraceptives, cocaines, and cyclosporins may cause increasing pressure also. For this, it's very necessary to take the history of taking of these types of medicines, and of course you should, if your patient has high pressure because of this, you should of course exclude these medicines. Next is arterial hypotension. Hypotension when arterial pressure less than 100, systolic less than 100, and diastolic less than 60 millimeter Hg. There are types, of course, primary and secondary. Primary is neurogenic, secondary may be endocrine because of deficiency of adrenal gland hormones, thyroid gland hormones, or pituitary, and sometimes maybe metabolic or organoischemic reasons. Mechanisms, of course, developing of arterial hypotension may be because of decreasing of minute and stroke volume of heart, because of decreasing of blood volume, decrease in peripheral vascular resistance, and decreased venous blood flow to the heart. All disorders which can result in these mechanisms cause arterial hypotension. Which symptoms of arterial hypotension? Acute form. These symptoms are represented of tissue hypoxia, especially of brain hypoxia, dizziness, short-term visual impairment, unsteadiness of gait, pallor of skin, fainting. Arterial hypertension, of course, for example, because of decreasing blood volume, or because of decreasing adrenal gland action in adrenal gland insufficiency syndrome, or because of deficiency of thyroid hormones, or because of deficiency of pituitary hormones, may have chronic clinical appearance, like weakness, irritability, sensitivity to weather changes, emotional instability and apathy, distraction, lethargy, excessive sweating, violation of thermoregulation, sensitivity to changing climatic condition, shortness of breath and palpitation during exercises, dizziness, and etc., headache, and all these clinical picture with the arterial hypertension, which you got 5 by BP measuring. Also by using of whole laboratory instrumental methods which you provide in arterial hypertension, of course you could find real causes of arterial hypertension. Okay, thank you for your attention.